everyone. I'm Crystal. I'm the Clinical Solutions Manager for TAGNOS. I'm joined by my beautiful friend Rachael Ellis with Hull University Teaching Hospital. Today, I've had the pleasure of working with her and her Scan4Safety team to implement TAGNOS Asset Orchestration. Thank you, Rachael, for joining us today. Can you tell us a little bit about yourself and about Scan4Safety and how it came to be?
Of course, thank you for inviting me for doing this. Thank you. So I'm Rachael Ellis. I'm the Scan4Safety Programme Director at Hull Hospital. Hull Hospital is a large acute hospital, 2 sites, approaching 1,300 beds, just shy of 11,000 employees, and has a major trauma centre, 2 helipads, and we pretty much cover every speciality that there is to cover on a medical basis. My team at Hull have been implementing Scan4Safety now for coming up for 3 years, and pre-COVID we were rolling out approximately every 10 weeks to a brand new area. We're live in 19 areas. We implement in a slightly different way to perhaps some of the other areas that run with Scan4Safety. And in the UK, Scan4Safety is seen as being a pioneering method of how actually you can implement scanning and brand new barcode technology to actually bring benefit to healthcare and to avoid risk and to not have duplication. And that actually brings big benefit to the clinician and ultimately to the patient.
Well, you answered my next 2 questions, I think. Your involvement with Scan4Safety. Did you touch on that one, or is there more details you want to provide?
Yeah, so Scan4Safety in the UK was originally started. It had 6 demonstrator sites. Each of them were funded to quite a significant amount of millions of pounds each. And after 2 years, almost a recipe of how to go about Scan4Safety, a rule book was written, and I reviewed that. My post was the first Scan4Safety Programme Director in the UK, which wasn't part of the central government funded, and basically my job was to implement as business as usual at Hull University Teaching Hospital, which we've now started to do right across. And the difference is really that we do is that we scan the entire patient pathway. We scan what's known as the 4 Ps, which is the patient, the products, the process, and the place. And the process is the what, so that's the staff members, and the and the who was involved with that as well, so staff and what procedure have they undertaken. So we will do that whether we are running with cardiac theatre and we've got a surgeon and the anaesthetist and the runners and the surgical care practitioners, etc., in the room with perfusionists, or we will also do that right down to ICU, where a nurse will be taking a set of bloods and sending them off for analysis, and we will understand that actually they've used these 3 components and this pair of gloves, and they've done it against this patient at this time in this bed space. So we run it right across the hospital.
That's a lot of data to track.
Yes, absolutely.
So you guys, you were the first director. Initially, this program didn't have a director type of role. And so
not that was funded, so they were all funded and then they were all dissolved back into business as usual, really, and then my role was created to be the standalone director post in the UK.
So you're over all the hospitals in the UK, or just your 2?
No, just for Hull. Yeah, plenty on my plate at Hull. So yeah, but ultimately, I also chair the Northern Scan4Safety group, where all the trusts come together. So a hospital in the UK is known as a trust, and they all come together. All the hospitals come together, and we talk about what it's like to implement, what the challenges that we face, how we got around things, what kind of things we need to be including in business cases and in development, and kind of how scanning errors have been reduced and the benefits that have been shown. So yeah, we also kind of share really quite nicely across the trusts within the NHS, within the National Health Service in the UK.
Can you explain what technology, strategies, processes you've implemented at Hull specifically?
Yeah, absolutely. So under the Scan4Safety banner, we've obviously got a central system that we use. We have inventory management, which is all about stock and products. So that helps us to have visibility to them, to automate orders, to make sure that we capture all the serial codes and that we know which product has gone into what location, so we can share products. So if we buy 1,000 of something, we can then give 10 areas 100 of each. Instead of having to buy 10 areas 1,000 each, we can do what's known as product splitting. So that's very beneficial. We can also track point of care, so we can track what patient had what procedure done at what time in what location. So that's really quite useful. And then finally, I suppose, really is the really big kind of exciting piece of RFID, which is kind of where yourselves have supported us greatly on that piece. So that's all about assets and finding assets and understanding what assets we've got and when they need servicing, etc. So that all brings it together as a complete picture for us.
Awesome. Your facility recently went live with this new product. It's the TAGNOS Asset Orchestration. You guys have a different name for it. And it was implemented with a partnership between TAGNOS, Zebra, and the Barcode Warehouse. Can you tell us more about that?
Yeah, absolutely. So we were allocated funding, really quite a small pot. It's quite a tight budget. We are the NHS and resources not widely available, so we have to get the best. It's a public purse, so we have to be seen to be spending the money to do it well and also to show transparency within that. So we tendered the actual product that was required, and that was done on outcome based. We knew what we wanted, but we didn't know how to solve the problem. We knew we wanted to be able to see the assets. We knew we wanted to be able to have transparency to the assets, to be able to perhaps share some of those assets and share some of that resource. But until you have visibility to that, you can't do that. So as a result of that, we tendered and the Barcode Warehouse won the contract, and in partnership with Zebra and yourselves at TAGNOS, they have now delivered this. So that to us is a great result. It means that we are absolutely, we've got the best value that we can, and that's a great outcome. So that's what we want to do and make sure that happens. But also it means that we have a great product. We've worked with yourselves to tweak that product, to modify it, to make sure it works for us in a UK hospital. And you've been really, really responsive to our needs. You've listened to what we want. You've kind of said to us, does this work? Does that work? And actually that collaboration work has actually been really, really beneficial, because apart from anything else, you have been able to learn what actually works for us as a hospital and how that moves around the hospital as an asset. But also we've been able to say, on reflection, we like this, but now can we make it better? And you've been able to also offer that sort of next step too. So that's been great.
That's awesome. Thanks for that feedback for us. That's what we strive to do. I mean, I think we can only be better when we work and listen. We really listen to what our end users and our clients, our customers are asking for. So we want to, we do have to work within limitations sometimes, but when we can meet all of your needs efficiently and easily, it's an awesome experience for us as well. Was there a particular reason you chose the Barcode Warehouse Zebra TAGNOS solution? You guys call it, what is it? Sorry, remind me again what you guys call it.
So to us, it's the RFID solution for assets.
Okay. Okay.
Yeah. So the reason why we selected Barcode Warehouse and obviously the partners with Zebra and yourselves at TAGNOS was multifaceted, really. So it had to be that it met our needs. That was first and foremost. It had to be that actually it proved to be value for money. And that was absolutely. But thirdly, we had to bring benefit to the patients, to the clinical teams that are dealing with patients day in, day out, overnight, in the middle of the night, when they need to be able to find a bladder scanner. They need to be able to find it, and the system has to be easy to use, has to be really transparent, and it has to be able so that they can just key in a few words and they can go and find it. So that's the reason really why we did it, and the fact that longer term we can future proof this a little bit more with you, and we can develop it a little bit more with you. It's not a static product. It's a product that can perhaps change and become improved and better as we need to. Dynamics change in the hospital, the reporting requirements change in the hospital, our requirement from central government, because we are totally central government funded here in the UK. That changes, and sometimes we have to change what we deliver, and sometimes how we deliver that, and that will change too going forward. So with having a team like TAGNOS that are available to us to actually listen, and when we say we need to change this, I'm fairly comfortable that actually, regardless of what is thrown at us in the next 6, 8, 12 months, TAGNOS will be able to listen. We might not get it right first time, but actually we will get it right. We will get, 80% right the first time, and then we'll tweak this a little bit more, and then we'll come back for some more testing, and we will get it right. I'm really quite confident that that will happen. So that was also a part of it for us, was understanding that actually there's some real flexibility there, and a willingness to learn and work with us quite quickly, because from start to finish, in only 5 months from concept, this is live. That's quite incredible, really.
That was going to be one of my questions. What was the process like leading up to the go live and the launch of the product? But
Yeah,
you've answered that.
yeah.
Like, we work really well with you guys.
Yeah, absolutely. And I think the more that we share, and it's never been. I remember there was a call actually, and I remember saying, I don't prescribe how. And I think you all kind of looked a bit shocked, but I don't prescribe how, because if you go to a doctor's, you do not say how you want the operation to be performed. If they've studied medical, for 8 years and have been practicing for another 15, you don't expect to then be able to tell them that, the heart valve, the tricuspid heart valve, does this and it goes. No, you don't. That's not the way it works. You say to them, I've got a problem with my heart, my breathing is doing this, these are my symptoms, and they will say to you, this is what you need. And you want an outcome which says that actually, you can run back to your 5K again without being out of breath. That's what we need. We need to be able to find assets. I really don't care how. I'm not a professor of IT. What I want is a system that's clear, a system that's user friendly. I want to be able to find my assets. I want to be able to have a relatively easily labeling process, and ultimately that's what I want. That's my outcomes. If you can provide that, I really don't mind if that behind the scenes goes up and down and round and about, or if it just goes A to B. I don't really mind. It's not my job to prescribe how. I think that's kind of why it's worked, and ultimately, I think for me, it basically has to work by me telling you what I see happening at the end. It's a bit like the Willy Wonka machine in Charlie and the Chocolate Factory. You don't really care how, you just want that everlasting gobstopper in your hand, and that's kind of where I am.
You got a gobstopper with us. You've told us before about when you guys were first looking into this and you realized, correct me if I'm wrong, you guys had like monitors, like you had them track how long someone was actually looking for a bladder scanner or another asset. And you had said that it was like an hour, like they would spend an hour looking for one single asset. A nurse was doing that instead of taking care of patients, correct? That like took her away from the bedside.
Yeah, absolutely. We did a time and motion study on 2 places in the hospital. So one was actually around ICU, and we looked at that, and nurses spent quite a lot of time looking for assets and finding things. And then we also did one on the theatre corridor, which is where a lot of theatres are basically forward facing, and that is I suppose really the main corridor for transportation of patients and of products and assets as well. There's storerooms going off it at one side, and there's theatres at the other, and there's sluice rooms and all of the things that you would expect from a major hub of the theatre corridor. But we looked at that, and it was 4 hours. I spent 4 hours with a clipboard stood there saying, what are you looking for? And out of that, we recorded over 3 hours 40 of people, clearly not all at the same time. So there was some doubling up of different staff members. But in that time, I think there was 11 staff members in total spent 3 hours 40 looking for products. And some of it were really simple stuff like cables. They were looking for cables because the pacing box, the thermometer temperature pacing box had gone. but no cables have gone with it. So you can't use that product until you can plug it in. So clearly we also need to then, we looked at and went, we need to label the cables separately because they're disjointed from the actual product. So we don't have many of those instances, but yeah, we do. And it just so happened that on the day that I did the time and motion, there was quite a lot of time spent looking at it. However, we're now about to go back and do that. And I think that we're aiming to reduce that by 85% in the areas that are live, which is quite incredible. We've not done that yet. That's about to happen in the next few weeks. So I'll be able to keep you posted.
That's awesome. Can I just say before we move on for our non-UK listeners that theaters is the operating room.
Sorry, yes, yes, it is.
We call
Yeah.
it the OR,
Yeah.
you guys call it theaters. There was a little bit of I think when we started the project, like we had to like learn the lingo a little bit more to like translate it into what we call it versus what you guys call it. But it's fairly easy. It's just sometimes like they're not going to the movies. She's not standing outside the screening room. It's actually an operating room.
Yeah, it's an operating theatre. Yeah, absolutely. Yeah.
So I know you guys haven't been able to like go back and study like the time reduction that this project has hopefully implemented or created, but how are people receiving the solutions? Any fun stories you can share on that?
Yeah, they're using it quite a lot. Obviously with COVID, we are restricted as to which areas we can go live with, so that has hampered our efforts a little bit, in truth, but we have now rolled out, I think we've had over 150 users go in the system now, I'm led to believe, so that's quite substantial in only 8 weeks of go live, so I think that's very good, and that's individual users, so I think that's very good, and lots of people have said, isn't this really simple to use and doesn't it look great? But lots of people like the map view. So our map view is sort of colour coded by area. So by each part of the hospital. So for each operating room, you know, theatre, then those are colour coded according to different parts. And then when you move into ICU, that's a different colour because generally when you are a clinician, you are based around a certain area by specialty usually. So you are either around the surgical part or you're around ICU or you might be in recovery. You might be in the surgical admissions lounge. So you kind of always be set around your own specialty. So it made sense to colour code those accordingly because that makes it a lot more visible to everybody. And also they get used to thinking my area is purple, my area looks yellow, and therefore they can find things really quickly on the maps. So that's been really good feedback too.
Oh, that's good. That's good to hear. There's two stories you've told us before recently. One was about a napkin left on your desk, and one was about I don't remember who it was specifically, but it was a gentleman, and he was like, just wow. And it may have been two different gentlemen, and one of them was like, you mean these are my assets and this is where they are? Can I go get them right now? And you had to make him wait to finish his training on it. But can you tell us about those instances?
Yeah, so we went to a ward that had been closed previously for COVID, and they'd kind of recently reopened in the last few weeks. And basically, the ward had been stripped while it had been closed because lots of people had borrowed assets that weren't theirs. And when we were showing the sort of nurse in charge, he basically said, "So these are all my assets here?" I was like, "Yeah." And this is where they are? I was like, yeah, right. And he said, I'm going to send somebody to go and get them. And I said, well, you need to finish your training first. And he said, no, they're going straight away. And I said, well, you know, I don't really want to cause mutiny. Why don't you wait until you need them and then you can go and find them? No, they're my assets and I'm having them back. But actually, you know, in a serious note, actually, they do belong to that ward and they are needed by that ward. So ultimately, but he can now find those assets and he now knows where they are before he then has a nurse that goes, we used to have one of those in that cupboard, but it's not there anymore. Where is it? Actually, they can go and do that. And often wards do share kit, and that's not a problem at all. But I think that when wards need to find something quickly, the point is now that they can actually do that. So that was kind of the piece, and he was almost ready with a list saying, I need to get all my assets back. So there wasn't hundreds of assets, just to be very clear, but there was a few, and they clearly belonged to that ward, and he wanted them back. So that was that one.
Rightfully so.
Yeah, absolutely. And then another example was when, you know, like you said, I had a note left on my desk, and basically it said, "This system is awesome. I love it," because they could find what they were looking for. They, you know, the team of being kind of, I'm sure we had one of those. Was it over there or was it over here? And actually, it became really quite clear when he kind of just typed on the list and he went, no, it's actually in 2 wards down the flight of steps, and it's round the corner. Go and get it. And they did. And he said that was just fabulous, just great that they could actually do that. So yeah, absolutely, really, really good examples where people were generally kind of, you know, sort of jaw-dropping moments of wow. You know, so that was really good, yeah. So yeah, we're just kind of hoping that kind of continues now. So yeah.
That's amazing. What recommendations do you have to other NHS sites when implementing solutions such as this, or when implementing any Scan4Safety products in general, or projects?
Yeah, I think we always start, and it's a big ethos of mine, is solve the problem. Because actually, if you solve the problem, the engagement happens. So if the problem is that they don't have visibility, then provide them with that. If the problem is that actually, you know, they think that they've got 40 of this, whatever it is that they think they've got, might be a, you know, kind of a thermometer, or it might be a monitor, you know, or it might be a blood gas analyzer, and actually they haven't, then solve that problem, give them the visibility, and show that actually in the last 12 months we've only seen 16 of those out of the 40, so therefore 24 are no longer on site with us. Solve the problem and the engagement will happen. And if you do that across both clinical and operational aspects, that comes together quite seamlessly. And then what happens is you almost have a waiting list of people, which is kind of where we're at with Scan4Safety, because lots of people are almost tripping over themselves going, I really want to go live with this. This is something that I want to do. But, you know, kind of because you can solve the problem, you can give them the visibility. You can show how everything works, and basically how it all slots together. You know, they've got visibility about their stock. We can show them when things are going to expire. They don't need to go and check the valve cupboard anymore, because when they scan it in using the GS1 barcode, it gives them the expiry date. So it connects all that together, and then they can literally look it up and say, in the next 3 months, what have I got that's expiring? And if it's on consignment, they'll get that exchanged with a supplier. And if it's not, then they can either look to use it, or we can make a decision to scrap it. You know, we can always look to do that with a proactive approach, but it's too late when you scan a product and it says this is now expired 3 weeks ago. That gives you no options whatsoever, and then you have to make a decision. If it's life and limb, do you continue to use it, or have you got another one on the shelf? That's not where we want to be. You know, transparency lends itself to trust, and with trust, then you get engagement, and with engagement, you know, we get great feedback, and we also get people wanting to work in collaboration with us because we're solving the problems. So that for me is the much bigger picture. And that for me is why we do what we do, and how we do what we do is solve the problem.
Wow. So what's next for Hull in terms of technology solutions? Anything you can tell us about that's in the pipeline?
Yeah, so obviously we're looking at the RFID piece. There's lots and lots of solutions that we can do, which are known as use cases. So we can do lots of things with this. So we could potentially look at contact tracing. That would be an amazing thing to do. We can look at patient belongings. That would be great too. We can also look at bed movement going forward, to understand where, almost from a clinical command centre, where beds are free or beds are not free. And then potentially, if you can layer that to your resources that you've got, your assets that you've got, and the patients that you have, ultimately you can almost become a logistics sort of wizard, really, because you can move nurses around to meet demand, which is what we're not good at doing right now, because it's really tricky to forecast when people are going to walk into A&E, you know, into accident and emergency. It's really difficult to forecast that, even though we have lots of patterns, etc. Weather affects it, you know, what's on the telly affects it, COVID affects it, the figures affect it. So, you know, people's sort of time of day affects it, of when they can do things. So actually there is no real trend that you can do that, but if you could see that in live time, you can then make decisions about moving resource around, about moving assets around, about understanding whether you've still got enough bed space to do what your planned operational works were for the rest of the week. You can make that decision on a Monday evening, because right now the bed you know, the bed spaces look like this. So with that kind of level of transparency, gives you a much greater leverage of actually moving the assets to where they are and being overall better for that patient. And better for the staff. You know, the staff are dealing then with patients that they want to deal with, and they're not dealing with 12 of them that are in a row all waiting to see them. They're not stacking up behind and forming a line or a queue, as we know in the UK. So actually that's the big piece really, is lots and lots of future use cases for RFID.
Awesome. Based on what you've learned so far, do you have any recommendations for improving Scan4Safety in general?
Yeah, I think Scan4Safety for me really is all about the patients. So you need to put the patient in the middle. And you know, everybody who talks to me knows that I bang this drum quite regularly. But ultimately, if it's a patient safety programme, which it is, the patient needs to be in the middle, and therefore we need to start tracking the patient all the way through. We need to be looking at all of that data and understanding where our resources are going and how that's all playing out. And I think when you do that better, you can then start to perhaps even get to profiling and to get to understanding where potential patterns and trends are happening. That would be really amazing. I mean, we're quite a way off that just yet, but we can look to do that kind of modelling in the not too distant future, I think.
Data is your friend, and it can help you grow a lot in leaps and bounds when you use it, when you have it and you use it appropriately.
Yeah, absolutely.
Well, Rachel, thank you so much for being here today and joining us. Congrats on all the success you guys have had with Scan4Safety and the NHS. Is there anything you'd like to leave the audience with today?
No, just to say, don't be frightened of it. You know, new technology is a little bit daunting. I would say, if you're really thinking about this quite seriously, I would say work out what it is that you want to deliver. What do you want to benefit from? What are the problems that you want to solve? Because they're the things where you should start and not where you should end. So for me, that's not the end, that's the beginning. And then you can work in collaboration with people and suppliers and partners that you trust to actually deliver things in a really kind of way that actually feels quite, I suppose, really, it's quite glib really, but it feels quite doable. So they're in bite-sized pieces that doesn't overwhelm you, and therefore you can feel completely overwhelmed very quickly with new technology because you perhaps don't understand the language, or you don't understand the hardware or the software or how it's all going to work. But if you focus on the results of what you want to achieve, then it becomes less daunting because other people will play their part to help you understand how. Don't worry too much about the how, worry about the what.
Right.
I would say worry about the what and worry about the why. Why are we doing this? You know, kind of, you do need to challenge that a little bit, and you do need to say, this is why we are doing it, and this is the what we are doing, and be very clear on that so that everybody says, yes, I understand what we are doing and why we are doing it. And then scope creep happens much less because there is ultimately a very much a line around the start and the finish. People understand what is expected and where they're going. And that then delivers the results because it clearly focuses people. Because if you focus on the outcomes, you know, people only do what you inspect, not what you expect. So as a result, that's probably the best way to describe it, because that, you know, if you are inspecting what your outcomes are going to be, you're going to get them.
Wow. And that goes back to what you said earlier about it's your job to ask what and why, and it's our job to tell you how. You know,
I think so.
That's amazing. That's such a great perspective. Thank you so much for sharing it. It's been a pleasure having you here today. Thank you for doing this with us.
Thank you.
And we appreciate it. And we love working with you guys. So we look forward to any projects coming in the future.
Absolutely great. Thank you.